You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Welcome to the Cancer Assistance Show. I'm your host, Dr. Bill Evans, and this morning I'm talking with Dr. Ronan Foley, who's a hematologist and oncologist at the Juravinski Cancer Center and a specialist in the management of multiple myeloma and the treatment of malignant diseases with CAR T cells, which we're going to be talking about later today. But before we dive into conversation with Dr. Foley, I thought I'd just mention some of the services that the Cancer Assistance Program offers. And the mission of CAP, as we sometimes call it, is to support, educate, and empower individuals and families touched by cancer through our programs and the services, which are all provided free of charge. And they include free rides to and from the cancer center or other medical appointments, the loaning of free equipment to help people stay safe in their homes, and ambulators, wheelchairs, other aids, nutritional supports, incontinence supplies, and a host of other things. So the Cancer Assistance Program really provides practical aids to people who have cancer. And so if you're listening to this and you're in the Hamilton area, check out the Cancer Assistance website, cancerassist.ca. There may be services that we can offer through the program that will be helpful in your cancer journey. So welcome, Dr. Foley. I'm really pleased to have you here today and to delve into a disease that isn't that common, but is terribly important. Multiple myeloma, a disease with kind of a strange name in a way, but maybe you could tell us a little bit about what multiple myeloma is. We know it's a disease of the bone marrow, but much more than that, probably our listeners don't know.
Yeah, no, it's a great question and a name multiple. So thanks for being here today and having me. Also agree 100% that the Cancer Assistance Program does amazing things, and I hear it from the patients every day. So God bless for that. Multiple myeloma is essentially a cancer of white blood cells. So the white blood cells we have that protect us and prevent foreign invaders and germs and things like that, they're the cells that ultimately become multiple myeloma cells. These white blood cells, typically they're called B lymphocytes, and their kind of goal in life is to produce antibodies. And so, which is an extremely important part of your immune system, keeps us healthy. And of course, when you go and have a vaccine, be it the flu vaccine or COVID, it's these plasma cells, these white blood cells that produce antibodies are the ones that are kind of doing all the work. So again, very important. But for reasons we're beginning to understand, these white blood cells or plasma cells, like a plasma TV, plasma cells, begin to grow on their own in an uncontrolled manner. Their zip code really is in the bone marrow, is where these cells end up being.
That's their home.
That is their home. But occasionally, as they become more and more malignant, they'll leave the bone marrow and start to grow in other places. The condition occurs when you have more than 10% of your bone marrow with these myeloma cells, and you have other myeloma-defining things like kidney failure, anemia, and then holes in the bones. That can be quite painful. Another condition where the calcium level goes high, and so taken together, we call that CRAB.
CRAB, yes. I've seen that acronym, and it's one way of remembering all the signs and symptoms of the disease, right?
And it's also important to know that the condition exists in earlier phases. There's something called an MGUS, which is just having an abnormal protein in your blood. And then there's a more distal condition called smoldering myeloma. Neither of those need treating, but most people will progress and then eventually develop myeloma. And of course, it's our job to properly diagnose it.
And that's a bit of an interesting part of the disease too. How do people typically present with myeloma? And because I'm thinking particularly from the family physician's point of view, it's not a common disease. It's only about 1% of all hematologic malignancies, I think. And it's only a few people per 100,000 that will get it in their lifetime. So it's really relatively rare. So I feel for the family doctor who might have someone come into their office with complaints of fatigue because of the anemia, maybe thirst, peeing a lot because of the elevated calcium, things like that, or bone pain.
All of the above. I mean, you're 100% right. So the root constellation of symptoms, the CRAB, hypercalcemia, renal failure, anemia, and bone lesions, it could be any one of those. But more commonly, because you have a population of plasma cells producing these antibodies, the levels of protein in these antibodies get very high. And sometimes a screen called a protein electrophoresis, which is a simple test that happens in a family doctor's office. That's where you see it. And so you'll see a large spike of a monoclonal protein, and that tips you off that there's something wrong. So any one of those things is how people present.
And then to further diagnose it, the bone marrow.
Bone marrow is required.
And x-rays are interesting, helpful.
Yeah.
Some very characteristic things that can appear on, say, an x-ray of the skull, I gather, right?
Yeah, so it's interesting. The myeloma cells send messages to the bones that want to destroy the bones. And so if you have a cluster of cells in a certain marrow-forming area of a bone, those local secretion of those, they're called osteoclast activators, will cause actually hole in the bone.
Yeah.
And so even on a plain x-ray, you will see a lytic lesion. But of course, nowadays we have escalated imaging more so to MRI and something called a whole body CAT scan. So we can get much more sensitive about seeing the lesions and at an earlier stage of disease.
And just for clarification to listeners, a lytic lesion is kind of a punched out area where the bone has been eroded. So it kind of looks like a whole lot of dark spots where you should see white on an x-ray from the calcium in the bone. Yeah, so it has a very interesting presentation. And you mentioned, I wasn't aware you're doing whole body CAT scans to identify, but the important thing about doing that, I guess, is to see where the bone might be weakened and therefore at risk of breaking, right?
100% true. And that certainly is one of our biggest worries in dealing with myeloma patients is, are there any lesions that are unstable? And sometimes we have to draw in our orthopedic colleagues to advice about pinning them or even dealing with the fractures. But that, in itself, not just because of the pain of a fracture, but you become functionally limited afterwards. If you've broken a hip or an arm or a leg, your journey through your treatment is going to be that much harder,
more difficult,
with those limitations. So certainly breaking bones is something we go, we make sure that doesn't happen. The second thing that can happen with this condition is the tumors can grow out of the spine, and that can put pressure on the spinal cord and even impair its function, like a paralysis. So breaking bones and spinal cord compression are kind of the big risks or things we want to make sure aren't going on.
Now, with the plasma cells taking up more and more space in the bone marrow, they sort of crowd out other cells and functions as a result. Does it have an effect on your ability to fight infections? You're producing this antibody, but it's a monoclonal, meaning just one type. You need a whole bunch of them to fight all the microbes in the environment. Does it make you at more risk?
You're 100% right. It has an effect on the remaining healthy immune cells. But as we'll get to, the concern about infections is actually made worse by the treatments. The treatments are remarkably effective, but they ultimately have a risk of infection. So that becomes more and more important as patients get treatment.
It was like a refresher course in myeloma for me. Way back when I trained, I actually trained under someone who was considered a world expert at the time, Dr. Daniel Bergsagel, and wrote the chapters in the major textbooks about multiple myeloma, but it seemed a lot simpler then, especially around the treatment aspects. Because once we went through those diagnostic tests that you were mentioning, and they were a little more limited then, I think, we had only really one therapy to offer, which was an oral agent called melphalan, and we combined that with prednisone, which catabolizes the protein a little more quickly. And people did benefit from the treatment, and we watched the spike in the so-called M protein come down. And those patients would do well for a time. But after that, got a little more desperate, and we try some things like cyclophosphamide and prednisone, or CCNU and prednisone, but we didn't have the panoplia of therapies that we have today. And it seems to me about maybe 20 years ago, all of a sudden things changed. And tell us about that change, because it's really quite exciting.
Yeah, it's been a remarkable journey. And Bill, me like you, I remember it was melphalan and prednisone and sometimes dexamethasone, but that's all we had. And, typically patients would do well for a period of time, but then when the disease became refractory or came back, there really wasn't much to treat people with.
Yeah.
Sometimes we'd give some radiation. So the journey of all these drugs, and it has been a remarkable journey, the first sort of major bit of success was with the drug you talked about, melphalan, which was the first drug. But we realized we could give it at very high doses in the context of a stem cell transplant. And that was really the first time we moved the needle with this disease, that people would go into remission and the remissions would be quite durable. The next phase was novel therapies, and they have really dominated the last 10 years with drugs that work differently than chemotherapy. They have different mechanisms of action. And there are three big ones, something called a proteasome inhibitor, PIs. There's a few of those. Something called an IMiD, which is an immunomodulatory. And that's a drug called lenalidomide. And then the third one is a monoclonal antibody, so an immune type of therapy that targets CD38. That's called daratumumab. And so those agents coming into the game and used in different combinations, really, the whole thing took off from there. And whereas the median sort of time with disease would be 3 years, it's now all well over 10 years for the majority of patients.
That's remarkable.
Yeah.
But still not a curable disease.
Still not
correct?
curable.
And I guess that's the holy grail we're still seeking after here.
That's correct.
Getting closer.
Yep, that is correct. So, it's not just about going into remission now, it's going into deep remissions where you can't find any evidence of disease. And we do that through testing called MRD. And this is a very sophisticated, high-level test that can get down to hundreds of thousands of cells. And if we can't find any myeloma cells, then you're considered MRD negative. That'll be the path to cure. Deep remissions, MRD negative, and then eventually the cures is what I believe.
In your lifetime.
Close. I hope. Yes, we hope.
Yes. Now, when people are on these treatments, let's take the first two, the proteasome inhibitors and the IMiDs. How do people feel? Do they have a pretty normal life and able to do things, or is it something, everybody knows chemotherapy makes you sick, right? Is it the same with these drugs, or is it much better?
Yeah, it's a great question. I mean, every drug, nothing comes free. So, I mean, every drug has something, but without question, not even a maybe, these drugs are very well tolerated. So they're not hair-losing, vomiting chemotherapy drugs. The way they work is entirely different and a lot more sophisticated. And what we're able to do, and what has always been the limitation with this disease, what we're able to do is attack it from different directions, and that turns out to be extremely important. Myeloma, and you're 100% right, it isn't curable, and the reason it isn't curable is you treat it, it becomes resistant. You treat it, it becomes resistant. You treat it, becomes resistant, and each time the remissions get shorter and shorter, until eventually it's entirely refractory. By combining drugs, the chance of it escaping and becoming refractory is a lot less. So these combinations, initially were 2 combinations, but now 3 combinations of drugs have been unbelievably effective. The thing is, you got to stay on them. And so that's the challenge right now is people are on the drugs, they're doing well, they have a good quality of life, they have manageable side effects, but they can't necessarily stop. And so that's one of the challenges.
One of the more recent additions to the therapeutic armamentarium, if you will, was the monoclonal antibody you mentioned, the daratumumab. Can you talk a little bit about what it's targeting and then how it's kind of moved from a third-line therapy up towards the front end of treatment?
Yeah, daratumumab has been a complete success. It kind of took the game book from treating lymphomas with a different target, but these are manufactured antibodies that have a very specific target on them, and if the tumor cell has that target, these guys can come in, bind, and essentially kill the cell. So it is very targeted, and that means the side effects are a lot less because you don't have as much off-target effect. It's all going after the myeloma. Certainly in the case of lymphoma, monoclonal antibodies knocked it out of the park. They were, making people live longer, and they were a game changer. And it took a little bit of a while, but it, the same strategy came into myeloma with daratumumab. In the beginning, we were just giving it by itself. We realized it was very effective. You could combine it with other drugs, and then the results were even more amazing. And now it's used up front. So if you're not having a stem cell transplant, you'll be getting daratumumab in the front line. And of course, all drugs work better in the earlier lines. So it's found its place. It's found its home. It's now given subcutaneously over 5 minutes, so it's quite convenient. And it's been a game changer, without question.
I guess the only negative associated with it is something called cost.
Yes.
Because all of these drugs tend to be expensive until they become generic, and then price start to fall. But as they enter the market, they're like $10,000 a month or more, and daratumumab or all the monoclonal antibodies are in that kind of class, aren't they?
Yeah, no, and I suspect if you looked at the global budget, Bill, and you'd probably know better than I suspect it's up there in terms of, drugs that are costing money. That said, and, this is kind of going back into the memory banks a bit, but, I used to remember myeloma patients coming in, they'd have terrible pains hobbling in, and, you try to figure out ways to control their pain. People come in now and they're telling me about their golf score and what they're up at the cottage on the weekend and this and that. So if you get the disease in remission and the medications aren't too bad, people have a good life.
Yeah.
And that's kind of where we're at now. Obviously, from my end, it's worth the money from what I see. But
and I'm sure from the patient's perspective, and thank heavens we live in a publicly funded healthcare system.
Yeah, I absolutely. I couldn't agree more.
Because the financial toxicity, if you were to have to pay for this out of pocket,
it would be impossible.
Yeah. Now, there is a role for bone marrow transplant in some patients, is there not?
Yes.
Can you talk a bit about that and how you select the patients for a bone marrow transplant and how their initial treatment would be different from, say, a 75-year-old who's got some comorbidities?
So your best results with a patient, I tell patients this all the time, your best results come from what we call 1L therapy or first-line therapy. And a patient, remember, they might go through 1L, 2L, 3L, 4L. But your first line of therapy, 1L, is when you get your most bang for the buck. And for patients that are young enough, fit enough, that we feel can safely tolerate, we don't want to put people in harm's way, a stem cell transplant is the way to go. And we find that patients having the stem cell transplant very often go into a deep remission. And then they can receive a medication afterwards called maintenance to keep them in remission. And after a transplant, it can be 5, 6, 7, 8 years before the disease comes back.
Also, they can get a very long remission and essentially minimal maintenance therapy.
Right. Just very well tolerated maintenance therapy. We, it was interesting. So the stem cell transplant data always looked better than people that will, as you said, were non-eligible for transplant. It is interesting to note with the daratumumab coming up front now and combined with Revlimid and dexamethasone, they do virtually as well as the stem cell patients now. So the drugs have caught up with doing the transplant. But to your point, the transplant remains standard of care for certain patients, maybe up to the age of 70. You have to have a good heart, good lungs, good kidneys. You have to sort of be what we call ECOG, mobile and functioning and all that stuff. In bed all the time and things like that. So for a while there, we were getting up to 300 stem cell transplants at Juravinski. And the majority of them were myeloma. It's kind of backed off now with the new drugs and as an option. There isn't quite as many stem cells, but probably about 120 to 150 patients come into Juravinski from around our LIN, Credit Valley, Trillium Health Partners, Grand River, to have transplants. So that's still happening quite frequently.
So I think we'll take a break here and come back in a moment to continue the conversation and focus on a really exciting area called CAR T cell therapy, which is another relatively recent addition to the therapeutic approach to multiple myeloma and really a very dynamic lab. We'll be right back.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
All right, we're back with Dr. Ronan Foley talking about multiple myeloma, and we've already heard the tremendous progress that's been made in treating this disease, but more recently, it really has taken, I would say, an abrupt turn towards a dramatic introduction of a therapy called chimeric antigen receptor T cell therapy, and it's quite a mouthful. That's why we call it CAR T. And I'm going to leave it to you, Ronan, to explain what CAR T cells are, number one, and where they fit in the therapy for multiple myeloma.
Yes, a bit of a CAR T party. So no, it's a great question. Maybe I'll just step back a little bit and, Bill, as you know, the war in cancer always kind of historically involved radiation, surgery, and chemotherapy. The fourth dimension is immunotherapy, and that's harnessing the immune system to attack the cancer cells, which probably is what it's meant to do in a normal situation. For whatever reason, the immune system doesn't recognize the cancer and the cancer grows. So, like other diseases, immunotherapy looms large now in myeloma. And it turns out some of our best results happen when we're engaging or targeting the immune system to treat the cancer. So CAR T is just a beautiful example of that. We had, in the beginning, we said that the primary myeloma cell is a B cell derived from a B lymphocyte called a plasma cell. But in CAR T, we're talking about the other side of the house, which is T cells or T lymphocytes. T lymphocytes are a remarkable part of our body and part of our immune system. They have the ability to, kind of in a hand-to-hand combat, identify a cell and kill it through various mechanisms of granzyme and perforin. These T lymphocytes also have a remarkable ability. If you get sick, if you get a viral infection, they can go from 10 cells to 10 billion cells in about 24 hours. So they have a remarkable ability to expand. And of course, they become the soldiers to fight the infection. And they can persist. So every time there's a reaction, some of them kind of pull back and remain as memory cells. So watching or seeing a patient going through an infection, this rapid increase in these lymphocytes, which are powerful killer cells, you think, geez, why can't you harness that to kill the myeloma?
Right.
And for whatever reasons, the cells are there, they're kind of swimming by, but they don't recognize the myeloma. So the myeloma kind of gets off free without the attack. If you collect those lymphocytes from a patient, and we're talking about billions of these lymphocytes, we do that through a procedure called leukapheresis, and which is similar to dialysis. It's you go on a machine for a few hours and collect all your white blood cells and T lymphocytes. Those cells, the T lymphocytes, can be genetically modified to have a very specific receptor on they produce it. So into their DNA goes a new gene. This is gene therapy. And from that day on, that cell will produce this receptor to recognize the myeloma cell. But not only that, that cell gives rise to daughter cell, to daughter cell, to daughter cell, thousands and thousands of times. So one cell can quickly become 1,000 cells. And so CAR T therapy ultimately is a living drug, because you put these cells into a patient, small number, they expand and expand, they wipe out the myeloma through this immune mechanism, and then they stay in the body for, we've seen them now 3-4 years, they're still there. If the cancer tries to come back, they just get snuffed out, and that's the procedure.
It's fantastic, and you made it sound simple, but I know it's not, because there's a whole process after the leukapheresis of manufacturing, which
right.
is kind of almost a weird concept to think about, that you're taking somebody's cells and then sending them off to a manufacturing center to actually be tailored for their job as the new foot soldiers, in your analogy, to fight the myeloma. Maybe just talk a little bit about the logistics there, about after you've taken the cells, where are they going to, and how do they get there, and what happens when they get there, that sort of thing.
Yeah, no, great question. So, yes, the cells are collected at Jurabinsky, but then often that night they are shipped off to California or New Jersey. There's a few of these manufacturing labs, depending on what product. And of course, this is taking off big time, with multiple new diseases getting CAR T therapy. So there's a lot happening in this area. Basically, the cells arrive and they go into a laboratory where people are wearing hazmat suits, and it's the real deal. The cells are initially selected, purified for the right lymphocytes that we want. They then undergo this gene therapy through a viral insertion of the gene product. They're then expanded, but it's mainly laboratory things and cells growing in incubators and things like that. It takes about 10 days to get the product fully ready to come back. So the cells fly out, they go through customs and all that. There's a ton of logistics to it, as you might imagine.
Yeah.
And of course, the place down in California has to be ready for them. And so a ton of paperwork and labeling and preparation. And so we have absolutely excellent coordinators at the Jurabinsky that kind of take care of all of those things. Cells come back, they arrive, and then we get started and use them right away.
So there's a bit of a delay from the time the cells are taken to the time that the manufactured cells can come back. Do you have to do anything in the interval if the patient's disease is progressing, and you have to bridge them over with drugs?
So the thing about the CAR T cells is they don't necessarily care what has been used before. If you have the target on that cell, it will kill it. Doesn't matter if it's had radiation or what chemos it's had in the past. So it's a very powerful thing. However, you do kind of conceptually want as little tumor in the person's body when you start the reaction, and that kind of favors more the CAR T. If you have, you'd rather be treating ants than elephants. But on the other hand, that period of time, you're 100% right. Well, it's what we call bridging therapy, kind of, putting a lid on the boiling water, as it were, just to kind of keep things over. And some people need that. We don't know if bridging is good or bad at this stage. Does it somehow?
It's still an open question.
It's still an open question, but sometimes you have no choice. Patients is progressing very quickly. And then the other part of it, and, hats off to the team at the Juravinsky. And, this is a multidisciplinary approach, setting the table for CAR-T. And Juravinsky, we were the second center in Canada to do this. But it really, a lot of people came under the tent to do this, all with expertise, because it's a remarkable journey for a patient from start to finish, and it needs a lot of expertise.
I imagine there's a lot of training that goes into getting everybody ready to do this, and frankly, some of the background to being prepared to do it comes out of the preparation for stem cell transplants.
Yes.
And being accredited as a center that can do that kind of work. If you can do that kind of work, you can kind of graduate to this kind of work. But if you've never done stem cells, must be a huge leap, or maybe it's not a leap you can even attempt. As a result, there's not that many places in Canada that do this kind of work. What's this current situation?
Well, so you've hit the nail on the head. It's so because of stem cells, centers will be FACT accredited, just like you said, and they're in a better position to take this on with the expertise they've developed. But there's only about 13 centers across the country that would be in that situation, that would be FACT ready and able to do this treatment. And clearly, given the size and geography of Canada, we need a lot more centers. But it's hard. I mean, Bill, from when you ran the cancer center, just to start up something like this, nobody's giving you any money to start up. So you're seeking in kind, and it's a real challenge. Will there be a day when smaller centers, community centers, maybe even rural centers are able to do this? I don't know. And it's what you said. There's so many pieces to this, and regulations and things. It would be a lot to take on. We have started looking at, we treat the patients, we give them their cells, and then shortly after they can go back home. And that worked for the stem cell transplants, like you mentioned, and we're trying to move in that direction. As it stands right now, if you're having CAR-T therapy in Hamilton, you have to come and stay for 30 days. We put people up at the stay bridge, and families and caregivers stay there.
Well, it's not simple to get it up and running. I mentioned 13 centers in Canada do stem cell
and CAR-T.
And CAR-T now. Well, that's a change in the last decade.
Yes.
From, I think you mentioned you were the second in the country. Seem to remember when there were only about 3 or 4 centers that were capable, which created a lot of challenges about selecting which patients have access. And is that still an issue now, that there's more patients than slots to put them into for treatment?
I think that's correct. Now, so some of the barriers to CAR-T. So, Hamilton's got this amazing new therapy, but if you live 8 hours away, and you might be eligible, the thoughts of it might be, I don't want to leave my home for 30 days and go and live in Hamilton. So, Bill, I don't know what's out there. What we're still learning about access, but there's clearly access issues. But we kind of need a plan B for the people that aren't able to get down here and commit to the whole journey, or don't want to, quite frankly. So there's a lot of fear and anxiety about doing it.
And I imagine there's some parts of our country that just don't have the resources to put in place, like some of our smaller provinces. And they can't all have CAR-T centers, so they're going to have to send their patients somewhere. It raises some very interesting and challenging ethical issues to think about how you make decisions for patients who live more remotely and may have financial barriers to coming to live in another city for a period of time with their family while they go through a therapy like this. I want to just step back a couple of steps, though. I don't think the manufacturing process is 100% perfect.
Right.
I think when it started, perhaps a more modest percentage were actually successful. Are they getting up in the 90% sort of range, or higher?
Yeah, no, they are. it is somewhat product specific. So some products struggle a bit more, and what you're talking about is 100% right. Products that haven't met the specifications. So to get the product approved by Health Canada, it has to meet a certain specification, something we call a COA, or Certificate of Analysis. And it's multiple points with very specific cutoff points. And if you miss just one single cutoff, the product is out of spec. And so it's what's called a manufacturing failure. And then either you have to go back and get more cells, try again, or in some instances, you can actually give the product sort of in a research type of way where they still make the product available and you can try, but it is out of spec. It's probably around 90 to 95% now of products are successful.
It must be very upsetting, to say the least.
Yes,
So
yes,
basically,
yes.
you prep them for all this,
Yeah.
you harvest their cells, you send them off, they're waiting expectantly to get their treatment, which, if not curative, at least has the promise of a very long remission.
Absolutely.
And then you have to tell them that they couldn't grow your cells for some
Well,
reason.
and of course, as you know, you prepare people for this ahead of time, right? That this could happen. Here's the numbers. But you're right. The stakes are high, and the emotions are high. The thing about CAR T is it's a remarkably effective therapy, but it's not 100%. So, certainly people that go into deep remission for a long time, that's what they were thinking. But there are still people where it doesn't work. And that can feel devastating because you were all set up for this remarkable thing. And then,
Poof.
yeah. So,
I mean, your hope
so
is
again,
dashed.
you try to set the expectations with the understanding this isn't 100%. This could fail. We could be looking each other in the eye in 2 months, and I'm telling you that it didn't work. So that at least people are prepared for that.
And CAR T cells have some interesting potential side effects too that
Yeah.
are unusual for therapies that we offer for other therapies for myeloma or other therapies for other cancers. One of them, because it works so well, can cause this cytokine release syndrome, and maybe just explain what that is. And I think early on it was kind of a frightening thing for clinicians, and not to mention patients, but that you've learned to manage that perhaps a little more expectantly and jumping on it earlier, so it's not such a big deal anymore. But then there's also neurological potential side effects that this can cause. I think people will be interested to hear about both of those.
Yeah, no, those are big challenges for patients going through CAR T. Essentially, to explain it, you have a CAR T cell that's kind of loaded up with this special receptor that can identify the myeloma cell. They come together and the CAR T cell kills it. But every time it kills, there's a little bit of what you said, a cytokine is released. And so the cytokines get released on the killing. That cell then divides and divides and divides. It becomes 1,000 cells or 10,000 cells, killing tumors very quickly within hours. And so it's like a chain reaction in a nuclear thing that over 12 hours, you can have this massive expansion and massive killing almost too quickly. And of course, we don't have the control on that at this point. I mean, the cells go in and they start cooking, and if they want to go in that direction, they will. And so all those cytokines build up, and just like you said, a cytokine release syndrome, and that can make people very sick. So their blood pressure can become low. They develop temperatures up in the 40s. They can have liver failure. And very oftentimes they have to go to the intensive care unit for pressors and sometimes intubated. So, within 2 or 3 days, you can have somebody who's, sitting in bed stable and being in the ICU in its worst scenario. That only happens about somewhere to 5 to 10%, but it's still, you need a hospital that has an ICU. And then sometimes in those bad cases, just like you said, it affects your brain and patients stop talking. It's almost like they've had a stroke. and they can become obtunded, and they can develop edema in the brain. So very serious things. And, so we're aware of it. The whole team's at the ready when a CAR T patient comes in. We have an antidote called tocilizumab, another somewhat expensive drug. But recognizing when this starts and getting on it right away is critical. So all eyes are on the patient, and early intervention gets away from those tragic cases in the ICU where, and people have passed away from that. So it's a devastating thing when it happens.
But getting on it early with that particular drug,
yes,
seems to be the answer in most cases.
And good old corticosteroids,
steroids,
dexamethasone, and it's recognizing it's starting. So it's really having that education baked into the system with, and Bill, it could be a nurse, it could be a house staff, it could be an R1 resident. I mean, whoever's sort of involved in the case. So we have very explicit algorithms for CAR T patients. In fact, CAR T patients have a special band on their arms to tell somebody that they are CAR T, and that then will ignite an algorithm that rapidly gets on top of it. So that's what the education was huge in setting the table.
And one of the things I find interesting and a bit challenging in trying to keep up with the literature is there are a lot of new CAR T cell products. So I guess we had Kymria initially, and yes, Carta, and now we have ida-cel and nita-cel, and there's some other cells.
Cilta-cel.
And so Cilta-cel, yes. And then how do you decide who gets what? And are we administering all these different types of CAR T cells in a single center, or does a center select one or two and work with those manufacturers? How's this playing right now?
Well, at Juravinski, we're using them all, but you're right. It kind of creates some challenges because there are product-specific side effects. Perhaps the product is handled differently based on what the company recommends for it. So there's several sets of books with one for each product, and I do wonder, to your point. I mean, how far can that go? Is there a red line of, okay, we can't have 40 different products. There has to be some consistency or some it has to be homogeneous to some degree. But they all do have their different quirks, and you have to have that experience. Which product it is may change how you treat it. And of course, this CAR T is the dawn of a new era, and it's coming in many diseases now, lymphoma, myeloma, but other ones. It may come into solid cancers,
solid tumors as well,
ocular melanomas and things like that.
Yeah.
So
it really is changing the face of cancer therapy hugely, and it also changes what you need in a cancer center to provide care. It seems to me it's like this shifting pendulum I've seen over my career, where initially so much was done in hospital because we needed to support the patients because we had chemotherapy, nothing else, and it was all quite sickening.
Yeah.
And then we got good antiemetics, and we could move a lot of the chemotherapy to outpatients. And then along came oral drugs, and the oral drugs were easy to deliver in the outpatient. So we kind of decanted things out of even the cancer center in large measure. You could just do it in the clinic and prescribe it, and they took it at home. And now we've got the pendulum swinging back towards the need for 30 days in hospital for a CAR T cell therapy. So you can never quite predict the future, right?
No. But to your point, there are efforts to try and transition this to outpatient. Various instances of the journey, there are times where a patient could be safely at home, but it's all about safety. And
I even hear about off-the-shelf CAR Ts, which is something else that may come along if people can develop the products, which would save this whole, I guess, manufacturing process and that time delay.
Right.
So, well, I guess we'll just have to wait and see what happens.
And for sure, that is one of the biggest limitations of CAR T is it takes time. Start to finish is going flat out is about 60 days, which for somebody with a malignancy, that can be a long 60 days, especially if their disease is unstable. So the products you talk about that are pre-made, kind of off the shelf and can be given within 48 hours, will solve that issue. The only issue there is if the cells aren't the patient's own cells, then there's always a risk of a graft versus host sort of process, which can be terrible.
So we have the complexities of CAR T cells and the multiple products now. We didn't talk about it, but basically because I can't pronounce the names of most of the drugs, but for all those proteasome inhibitors and inhibins, there are second and third generation, probably fourth generation drugs that can be used, and it gets tremendously confusing, and they're often used in combination. So you have so many acronyms swimming around up there. It's a bit overwhelming, and I'm sure it's overwhelming to funders. And I guess one of the things that's recently appeared in the Canadian scene is an initiative by what was called CADTH, Canadian Agency for Drugs and Therapeutics and Health, now the Canadian Drug Agency, easier to say.
Right.
Are provisional funding algorithms where they bring together practitioners, I gather 5 or 6 oncologists, who review the evidence and also bring their experience to bear on what should be the sequence. And what do you think of the process? Have you been involved in it for myeloma? It certainly would be helpful to have a roadmap that had all the signposts clearly marked as to what's the next step.
Well, I think it's clearly an important thing, and what CADTH has done in terms of laying out the sequence and the treatment options. And again, it comes back to, are you first line, are you second line, third line, fourth line, sometimes fifth line? What should you be doing? Because it's unbelievably complicated. It's a success story, but there's so many drugs, so many combinations. There's hundreds to thousands of clinical trials that as always, that's what we're basing our decisions on. And so as you said, there was expert review, and keeping in mind the Canadian scene, what things are available to Canadian practitioners. And I think it's very good. I think it's very comprehensive, very accurate. I mean, it may change in 6 months. It may change in another 6 months. But no, I think that's been important. I think a challenge is educating physicians across the country who may be in very different situations. I mean, those of us that work in academic centers are heavily exposed to the trials and rounds and things like that. But if you're working in a remote place and you're seeing breast cancer and renal cancer and myeloma, it'd be very hard to keep up to that level of care. But that's important. So education becomes huge. Groups like Myeloma Canada that are full court press on educating the whole country in these types of things. So. And even sometimes pharma themselves go out and give educational talks, which are very useful, provided they're fair and transparent about it. But education is a big piece.
So you touched on the topic of clinical trials, which is where I was going to go to probably next and last, because I know the Juravinski is very active in clinical trials, and you've been a leader in clinical trials of CAR T cells. What's happening there now, and maybe a little bit of prognostication? Where do you think this is going to go, and what's it look like in 5-10 years?
Yeah, well, the clinical trials are exploding because you have so many drugs and infinite numbers of combinations that all driven by science. I mean, they all have sort of a mechanistic rationale to them, but there's a lot of trials, and as some of them are phase 3 studies, so you're really confirming that a drug that looks very promising. Some of them are just trying out some new drugs, and some of them are first in human. They're trying drugs that have never been tried before. So it's a challenge for us. Which trials should we be doing, or where should we be focused? We kind of have a blend of different types. But that's one of the challenges for the research team up at the Juravinski is, should we kind of be focused on one type of trial? At the end of the day, we want the trials so that we learn, but we really want the trials as opportunities for patients, to get access to drugs they otherwise wouldn't in Canada. So we always keep our eye on that.
And your prognostication for 5 and 10 years from now?
Well, I think you're alluding to cure. So cure is a tough thing to talk about in that how long do you have to wait before you've done it? So what I think is happening is a test we talked about before. It's called MRD or minimal residual disease. People who are MRD negative, we think those are the ones that may in time be cured. The myeloma does not come back, and it has always come back. So when it happens that it's not coming back, that will kind of be the moment where you realize, wow, we may have cured people.
Right.
Are we there yet? I don't think so. Between the daratumumab that we talked about and the CAR T, I believe there will be some cures, and so just will take time to see that. That's kind of going out there a little bit, but no, in terms of your question, it's a new era, and it's really exciting stuff, but a lot of moving pieces.
Well, certainly a very hopeful era.
Very hopeful.
And I think for anyone listening who either has multiple myeloma or a family member who has multiple myeloma, you're hearing how much the treatment scene has changed, particularly in the recent times, how it's very positive and therapies are really yielding a lot of success. And maybe cure is just a little distance away at the moment, but perhaps not too far distance. So this has been a really interesting conversation. Dr. Foley, really appreciate your time, your expertise, and sharing that with us. It is one of the purposes of cancer assistance programs to bring practical aids to patients, whether it's travel to and from the cancer center, free equipment loans. But this podcast is a practical aid to help people who are out there who are confronting a type of malignancy and want to know what it's about and how it's being treated. And we hope that this podcast has shed light on the topic of multiple myeloma. Do want to thank the Hutton family. Hutton Family Fund funds this podcast, and we couldn't do it without them. So again, thank you very much for your time today, and to our listeners, thank you for listening. And just a reminder, we've done over 50 podcasts, so they're still available at cancerassist.ca. You can go back and into the vault, so to speak, and find any number of podcasts on various tumor types, supportive care services in our region, amongst other topics. So thank you for listening, and we'll look forward to talking to you next month.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca, or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.